Well, may I say it's a pleasure being back again with the three deans. As we first started, we thought this was really like the three tenors, but the singing didn't go very well, and that had to be dropped. But there are three of various types that could be done. We just haven't thought them through yet. But I appreciate the invitation to participate in this seminar. The breadth and diversity of bioethical issues have grown steadily since I embarked on my medical career. Inevitably, bioethics has had a growing impact on the nature and scope of work of deans, faculty, staff, and students. In public health, bioethical quandaries intrude with regularity. The resolutions are often tortuous and complex. However intriguing the challenges may be, decisions are usually requisite. And whatever the resolutions, there inevitably will be quite a number who know that the dean was wrong and are not hesitant to make that known. A few personal reflections. These are a bit dusty or perhaps moldy with time. I must first caution that my experiences as a dean terminated more than 25 years ago, and I hasten to note that we did have electric lights by then. But for perspective, I must point out that my service as dean preceded the tenure of one Summer, two Bushes, one Clinton, a Clegg, and an Obama. A great deal of water has gone over the dam in that time. For the first meeting of the three deans, we were cautioned strictly to take not more than 10 to 15 minutes to first review one's past personal experiences in public health and to offer gratuitous advice which might provoke response from the audience. Not an insignificant challenge given just 15 minutes. However, the time constraint forces a serious effort at oratorical brevity. And this is not an attribute, as you know, which is unfamiliar to deans. And thus, as I learned long ago, there was no way to keep me in check other than a written script. So tonight, this afternoon, a written script. Bioethical issues are now more frequently and openly discussed today than once was the case. They span the public health agenda. Some of the most important and controversial relate to incidents that involve human subjects and the preferential assignment of treatments and care and vaccines or whatever. One of the largest and most intricate of vaccine studies commenced in 1954, and certainly one of the most controversial at the time, although largely forgotten. It was just 2 years after Jonas Salk announced the discovery of a polio vaccine. It involved more than 1.8 million children, an array of community studies of a magnitude never before attempted. At that time, I was in my first year at CDC, working with Dr. Alex Langmuir, who was formerly here as head of epidemiology, and now directing the CDC epidemiology branch. And he played a significant role in shaping the studies we did, and certainly many of my views. A few words of polio history are worth noting. Polio had been little known until early in the 19th century. Many of these people have it in their mind that this has been with us over the centuries. It has not at all. It's fairly recent. It wasn't until the outbreaks in the 19th century began to be reported in Europe and then the United States. And the number of cases grew steadily and then rapidly and reached a peak of 58,000 in 1957. 1/3 of the cases were over 15 years of age, which made it a much more poignant situation in that young children were coming down with this and had to be carted around, and it was pretty obvious that this was a serious disease with long-term implications. One victim, of course, was Franklin D. Roosevelt himself. There was panic and concern far exceeding that which we have observed in conjunction with the emergence of Ebola or Zika. When I was a medical student in Rochester about this time, a polio epidemic of significance occurred, and as medical students, we were assigned to 8-hour shifts manning respirators. And our main job was really to aspirate pharyngeal secretions which accumulated, which we did with an ordinary rubber tube, no filter or other blockage. It was a different era. A special foundation for the treatment of poliomyelitis cases was founded and generously supported by donations. Many of you will know as the National Foundation for Infantile Paralysis, NFIP. The foundation was unique among the different foundations in that it supported the development of special research laboratories, and one of them was here at Hopkins with David Bodian and Isabel Morgan being the distinguished virologists. In 1952, it was clear, however, that the live oral vaccine was not yet ready for safety testing. That was the Sabin vaccine. Meanwhile, Jonas Salk, working at Pittsburgh, focused on an inactivated vaccine, a highly virulent strain of each of the three polio viruses, were to be injected after they were inactivated. So they're grown up and they were inactivated, and it's a killed vaccine as we refer to it. The tests in monkeys indicated that the inactivated vaccine was safe, but no one was entirely sure that monkeys would respond as humans. So there was a great uncertainty as to what to do. And there was a tremendous debate. The really serious problem was how to determine if these vaccines were both safe and effective in humans. The 1947 Nuremberg Code prescribed tests in humans unless there was informed consent. And here we were dealing with very young children, and informed consent was clearly out of consideration. Could there be adults that could give informed consent? There was a tremendous argument about this and trying to decide what to do, how to test the oral vaccine strains. Meanwhile, much to everyone's surprise, a virologist appeared on the scene who was not so well known for the work he was doing. His name was Hilary Kraparsky, certainly a very well-known virologist. But he was working at Lederle Laboratories, and he announced in 1951 that he had developed a live vaccine like the vaccine developed by Sabin. It was a type 2 vaccine derived, it was different, of course. And he also announced that he'd given it to 20 children, and it was safe and there was no difficulty. There was also no permission requested of parental or other legal guardians. So all that, here we were sort of stalled, or that's the certainly from the discussions I sat in on, the great concern as to what to do. The bioethical issues and options provided an unusually broad and intense national discussion and education on issues and options, spurred by the national concerns and anxiety for results. The Foundation decided to go ahead and support trials for safety and efficacy at the earliest possible time, and so began the planning for the largest vaccine control studies ever conducted. There was a small, steadfast group of epidemiologists who insisted on community-based supervised trials with a special emphasis on vaccine efficacy. Salk argued that there was no need for further trials, that the vaccine was safe, he could testify to that. He'd given it to many monkeys already, and he knew it was not a problem. Langmuir, who was then at CDC, was one of the most persistent, saying that we need further trials. We're going ahead with a large-scale vaccine, they must include trials. And so my exposure to many discussions as to how to do this, and the arguments were pretty widely disseminated about placebo-controlled trials, emphasized that then if you got good results, that polio did not occur randomly throughout the country, and how do you do that? How do you measure it? More cases were to be found among the poorest, who might be the least likely to be vaccinated, and how do you account for that in your planning and your studies? And if in doubt, in the milder cases, they may be living in poor areas, and the cases that were less marked might be assumed to be from patients who may have been vaccinated and therefore would be assigned in that category. So the arguments went on. The epidemiologists argued vehemently for blinded case control studies in diverse towns around the country, in which you would give a vaccine to one individual and placebo to others, and getting the vaccine later on. And that's finally the way they went. Some wound up giving it to first and third graders and leaving the second graders as placebos, and every imaginable dimension you can imagine, trying to decide how effective the vaccines were was almost impossible because of all the variants that occurred around the country. But it was a crucial learning experience in bringing to the forefront of medicine and public health the essential needs for case control trials, and many models were employed in fact. Indeed, 900,000 children in 211 counties in 44 states received vaccine and/or placebo, and out of this entire number, 148 developed polio. Huge effort made, huge problem, and so much confusion actually, as it's turned out, in the data that it's not altogether clear what the actual efficacy was. But it gave some impetus to the creation of human subjects review committees. The first was initiated in the early 1970s, shortly before my arrival at Hopkins. Its policies and procedures became national models whose blueprints were substantially conceived by a group at the school, with Marcia Pines as a principal secretary and NIH staff. In 1978, a little bit later, the Belmont Report summarized ethical principles and guidelines for all research involving human subjects, respect for persons, beneficence, and justice. Well, somewhat later, during my 3-year stint in the White House, we had occasion to decide about another group. and that was those who were flying for NASA, the astronauts. And there was no code provided for them at all. So after a discussion, that was passed. And finally, when we went to looking at overall the departments, we had one department left in which the code and bringing in the Belmont principles had not been adapted, and that was for education of all places. And they were the last one to fall, and it was amazing that, and with that, the common rule for human subjects was then throughout the country. But then there's been exceptional circumstances in which deliberate bioethical approaches have been bypassed because of emergency circumstances, and this we need to remember. The months following the attack on the World Trade Towers was such a period. As you will remember, we had the surprise attack, and subsequent to that, and that was September 11th. At that time, I was director of a new center we had here at Hopkins for civilian biodefense studies. But on the Sunday afternoon, right after the attack, I was called and said from the secretary to meet at 7 o'clock. And I said, like, this is Sunday, you want Monday, Tuesday? I went, what, 7 o'clock? 7 o'clock tonight. So I went down to the White House, or to the secretary's office. There were 7 of us sitting around, and what we heard was that there was, with fair certainty, there was going to be a second attack, and intercepts said it was likely to be smallpox. In fact, at that time, little had been done in emergency planning. And so my next 5 years were back in Washington looking at the question of what to do about protection against biological weapons. The smallpox vaccination and production had stopped pretty much throughout our country and other countries after eradication was declared in 1980. It was known that we had 18 million doses of smallpox in storage in after the event had occurred, but as we called CDC on the day following our first meeting, we learned that all the diluent had gone bad and could not be recovered, and we really were sitting with probably 10,000, maybe 15,000 doses of smallpox vaccine. And the question is, what to do? We had no vaccine production capacity in the United States, so we convened a small working group, 10 experts, and within a week reached a number of conclusions. The first, that a substantial quantity of vaccine should be produced urgently. We then ascertained that there were fewer than 15 countries with vaccine sufficient to protect their own people. So what we had to do was produce quite a lot if we were going to be looking to a global protection. And at the same time, no country is able to produce as much as a few million doses in a year. U.S. manufacturers revealed that none could produce more than perhaps a few million doses in less than 6 years. So we're sitting at that time wondering what to do. We've got almost no smallpox vaccine, no production capacity in the United States, and actually very little anywhere else. So what we did was decided to purify the existing vaccinia strain, which turned out to have a number of different components, and it turned out one of the 6 we selected. We converted production from growth and egg to tissue cell culture. We contracted then for production of the only place that we could get a lot of vaccine produced, and that was Austria, which had a large plant being developed for the influenza vaccine, which we could convert fairly quickly, and to move ahead. At the end of 18 months, we had 200 million doses of freeze-dried vaccine ready for emergency use. The only trouble was it was not the same strain of vaccine that we had. We had no experience in vaccinating patients with that vaccine. And the question of what do you do? And we went ahead with testing of it, but it was a very limited amount that could be done because we had to have vaccine ready, and the only thing we could do was go ahead and dry freeze it and have it ready to go. And that's what we did. So in effect, we had sort of really done nothing really in the testing of humans, of all the other things, but there was nothing else to be done. And in my own experience, there are many other circumstances we do wind up in. We would like to go through the bioethical examination of what's to be done and how and why, but in fact, time is short and there's decisions that have to be made. One thing I'm not sure about, though, is whether we can decide and act with sufficient speed when it is needed. As I have come to learn, we have another serious disease, which was not very evident when I was there, but has grown significantly since that time, and it's called epidemic interagency committeitis. It's merged and spread, and it's threatened on more than one occasion to paralyze Congress and even the country. And it's wonderful the way you have a small committee to talk about a particular subject. Each committee will have people from several different departments or other parts of government, and they, of course, want to participate and bring to bear all of the essence of what we have, intelligent. But you soon find that each of those usually has several committees that advise them, and little by little you start growing. And my great event was when we decided to do a smallpox study of a threat of smallpox, and what would we expect the dimensions of this to be, and we created a committee. And we started with 8, and the committee finally was running about 64 at every meeting, with about half of them on the telephone, and that was the way we finally concluded the exercise. And we thereupon chucked it in the wastebasket, and you haven't seen anything like it since. So I think the issues of bioethics are important. I think we made a lot of progress, and I think we're doing a lot of things well, but there are times when some careful discussion is needed without expecting half of Washington to participate. Thank you.